let us move ahead. Anna, are you all set to go?
Yes, I'm just gonna, hi, hello.
Absolutely, good afternoon.
Good afternoon. Shall I share my screen? Is that?
Yes, and then if you're all set, it's a great pleasure to welcome you and introduce you. You're from the London School of Tropical Medicine and Hygiene. Welcome.
Okay, I think I need to put the slideshow on, and then everyone should see this well. Can you see that clearly? Is that?
Yep, I can see it.
Well, hello everyone. I was really interested in the previous talk, and I think I'm going to complement it and pick up on some of the areas, but more from an economic perspective. So I'm Anna Vassall. I'm a Professor of Health Economics at the London School of Hygiene and Tropical Medicine, and I lead a large group of economists there who currently, many of them, their attention has switched to COVID. So I'm going to talk a little bit about that work, but particularly talk about the interactions between health and economic impact. And my original title was From Data to Decisions, but when I decided to prepare this talk, I realized the better way around is from decisions to data. So I'm going to begin with quite big picture stuff, but I think it's important as an economist to set the broader scene, as health economics really sort of investigates the allocation of resources both to the health sector and within the health sector, and economists tend to investigate things from a positive perspective, trying to describe and understand what's actually happening, but also economists like to step in and be more normative and actually say, well, we think this should happen. So from both those two different perspectives. If we look at pandemics, and I'm sure you're all observing this at the moment, the policy choice set that is faced by governments is huge and diverse. They're making choices over health provision, they're making choices whether to do public health intervention, social intervention in lower middle income countries, looking at humanitarian action, social protection policies, and sectoral and macroeconomic policies simultaneously, and deciding how best to allocate resources across those different areas, but also within each of those different areas. And while governments are trying to grapple with this huge range of policies, they're trying to achieve multiple objectives. It's not a simple objective function, if you like, but they're trying to simultaneously optimize societal welfare in terms of many dimensions, in terms of health, in terms of productivity, in terms of what we consume and the value we get from consumption and the benefits we get from it, and in terms of, as Deirdre talked about, how that is distributed, either from an equity lens or perhaps just a straightforward poverty lens. And at the same time, consider the implications of all those policies and the combination of those policies on national security. So many choices, but also not clear exactly what is being maximized when you're making those choices. And not only that, they're dealing with trade-offs between the short and the long run. So what can be brought forward today, what is really urgent to do today versus delaying benefits later on or bringing forward expenditures, which then may cause longer term issues. And again, within a sort of optimization choice framework, they're doing that within constraints. So you could have an economy where today you could suddenly change all resource allocation instantly, but in fact, apart from that overall budget constraint that economies have, and changes obviously depending on how much expenditure you bring forward today versus tomorrow, there are also rigidities within economies. In simple terms, for example, if you've invested in a hospital infrastructure or a certain type of human resources, you can't suddenly switch that. That capital investment is fixed. And in the very short term, the timeframes that pandemics operate in, governments are constrained. Likewise, on demand side, constraints in terms of the population. There are various constraints which stop people behaving rationally. That might be sort of understandings of risk, lack of information to make decisions, and also the way people consider their actions and how they affect others. On these constraints in pandemics, are not just defined within the domestic government, but in many cases, they're, particularly in terms of the supply constraints, are actually fixed globally, that there might be a global lack of resources, or one country using those resources will be constrained by other availability. And the normal price mechanisms that, you know, in the shorter, in sort of normal economic situations would resolve that kind of scarcity. Prices would rise, people would produce more, may not be able to occur in the time frame of pandemics. And not only that, this shift, if you like, this movement that needs to happen is happening against changing and evolving data and a frequency of decisions. So what I've described above might sound like a real mess and complexity, but in fact it is the business of governments. This is what governments do all the time. They have mechanisms to make these decisions and evaluate them, and allocate resources and procedures and planning procedures and decision procedures that support them. So it's not as though these kind of constraints and objectives and choice set is new, but it's the frequency with which it has to happen. And the fact that the shock means that you get an instant disequilibrium, that you get almost an instant mismatch between current resource allocation and what would benefit societal welfare. And that's continuous and keeps evolving. So really, from my discipline's perspective, one of the sort of fundamental questions, and I'll come back to this right at the end of the talk, for future pandemics, is the base that we normally use, or governments normally use, to make these decisions, how resilient and what needs to happen when you're in a pandemic situation, and how resilient are those systems when it comes to this kind of shock, or economic and health shock. So for those of you who are less familiar with this area, this is business as usual. It's an idealized form of business as usual, or a simplified form of business as usual in healthcare resource allocation. But over the last 20 or 30 years, and I'm sure in everyone's sort of different countries, if you look at NICE in the UK and different systems globally, a whole set of principles and decision processes and metrics to support them and data to support them has been developed to help people within health make optimal decisions. And these range from really comprehensive processes, which may reevaluate sort of all the services countries are providing and reset the benefit package, to sort of more incremental processes when new vaccines come along or new drugs come along, to decision processes about those. Do we add them into our overall benefit package? These decisions usually pull in different types of data. One of the first types of data is understanding the costs of any changes in resource allocation or additional allocation to health. And that can be the cost for the health sector, or it can be more broader for society in terms of, does this particular intervention, it could be a public health intervention, impact productivity, and how does that impact health sector resources? The other side, which I'm sure is the side that everyone's very familiar with, and Deirdre gave some great examples of, is taking in the information from health impact, and particularly infectious disease modeling and other types of modelings. But importantly, from the economic perspective, we don't just look at, say, health impact, this many lives saved or this many cases averted, but we also try to add in valuation. So to understand how populations, for example, value relief from blindness compared to preventing death. And in many countries, there are sort of national surveys and a whole scientific community sort of dedicated to understand how we value different health states and how that relates both just to the experience of those health states, but also our ability to function given different health states. And this sort of set of information in health economics is brought together to make assessments of whether one policy choice is optimal or not. And often that's in the form of cost effectiveness analysis, which looks at what kind of health gain you can achieve for different costs, and within your budget, does that maximize your health gain and your population health? Now that all sounds very formulaic. The process is, I'm sure everyone is listening to all of these things saying this process is sort of not as simple as that, and often in view, it's sort of, and we can't measure all those things perfectly. So usually when all this evidence is considered, there's this long process of evidence-based deliberation. And in some cases, other criteria also brought in that populations may find important to their welfare. So we've talked about it's important for populations to live in equity, to avert poverty, and those considerations may be brought into these analyses. And also people may bring in, particularly for public health, how populations value health gain versus how they view other things they can consume. And one of the examples of that are measures of something called the value of statistical life, which look at how much populations are willing to accept to take on a possible risk of death in simple terms. Though I'm sure the people who measure that would say that's quite a blunt explanation of that measure. But in business as usual, we collect all that information. The process may take up to a year, sometimes much longer, and may even evolve over a decade. And it's sort of built on the back ends of decades of research and model development. And one thing I should say, my background is in global health, and of course the situation and the ability to do this is very different across different countries. So I'm going to talk about some of the work we've been doing, and like Deirdre, this is a large team of people when I say we, and I'm going to, in my last slide, sort of explain who some of those people are. But when sort of COVID emerged, we got a sort of quick grant from the Wellcome Trust to try and turn some of the work that we've done in the past in TB, but also other diseases, in these kind of analysis, and see how we could apply it to COVID. And I'm going to talk a little bit about some of those experiences and the work we've done, and then reflect upon that at the end. So one of the first pieces of work we did in that list was to try and estimate the cost of COVID. As I say, my focus is in low and middle income countries. And here we take the kind of models that Deirdre talked about, and I'm sure you're all familiar in, and this is the most simple thing. And then, which is less simple, try and estimate the cost of the different aspects of COVID and link that to the epidemiological projections. So policymakers can begin to see the consequences for the health sector of different sort of interventions. So here is an example, on the top left, we have an example of the cost in terms of the overall total health spending over the first year of COVID, of an unmitigated epidemic. And this is done quite early on. So our understanding of the epidemic has changed. So this is really to give you an example. But here we saw our early projections were the sort of median impact on the health sector was 50% of current health spend in low and middle income countries of an unmitigated epidemic. And then if we look at the most sort of severe response, which is to have sustained 60% social distancing, we could reduce that impact on the health sector to 23% as a median percentage across the low and middle income countries that we're able to include. And likewise, we looked at that in terms of the percentage of GDP per capita, and that sort of ranges from 3%. And this is just the impact on the health sector cost. This is not the cost of closing down industries, but this is really just health spend, a median impact of 3% of total GDP, with an unmitigated epidemic, and 1% with 60% social distancing. Now, just to give you some sense of what that means. So in our business as usual, this is an example from Pakistan where we support the ministry there, prioritize health spending. And it's a bit of a complicated graph, but on the left, we have sort of the spending in a year across Pakistan. And it goes from, sorry, my screen picture has sort of blocked me seeing the things. I'm just going to move that a minute. And then we can see sort of from $17 per capita to $8 per capita. And if you go from left to right, this shows as you add different interventions to your benefit package of health services provided in Pakistan, how the costs increase. And we work with the ministry to try and prioritize and order those interventions and say, for example, if you have $8 per capita, which is this, I don't know if you can see my pointer, which is this sort of yellow, you can say, sort of include all the interventions up to, say, isoniazid preventive therapy for TB. And then what we do is look at the impact of COVID and say, well, actually now, if we take out the percentage spent in Pakistan, which we think will happen, this is actually the amount of available resources that will be left for other diseases. And if we were to allocate those other diseases optimally, we could only include these 12 or 14 other interventions at full population coverage rate. So that gives you some extent of, in one country, of the type of work, the type of impact that level of expenditure may have on the health sectors, which are already, very constrained. Sorry, I'm going to make this, I'm having a bit of trouble seeing everything. Okay, so I talked about the financial constraints and the work done there, but I think from early on, and particularly driven by high-income countries, most of the model estimates for COVID also looked at other non-financial constraints, and these are the rigidities. So even if you could choose to spend your money entirely differently tomorrow, you're not able to, or not able to build capacity in the way you'd want. And most people concentrated on intensive care beds and general beds. So we did a similar exercise, except for 5 cities in low and middle income countries, and try to explore early on how different scenarios would breach their capacity. And it's quite clear, and I think for many people working in those countries know that sort of ICU beds are extremely limited, and almost with any scenario. So if you see here, these are the non-ICU beds, and these kind of pink bars, that's the capacity level. These are the results of the different scenarios, and the one below is ICU beds. You can see very quickly in whatever scenario you were looking at, we were exceeding current capacity. What was also important for us, and I think from what I understand, I'm not actually based in the UK despite my British accent, but I understand became an issue in the UK later, that even if you build your ICU bed capacity, you have a human resource constraint as well. And this was less commonly done. But for low and middle income countries, we also looked at when or which scenarios would actually exceed the human resource capacity available. And that was taking in 60% of overall capacity within a country. So really shifting human resources swiftly. And still we found that most of the scenarios we were looking at would exceed those limits within a year. So then we realized that this this kind of constraint, it's not something that you can resolve economically by shifting resources. In fact, the consequence of these constraints is more likely to be on the health impact side, that you're not going to be able to relieve those constraints. So you need to start to figure out what this may mean in terms of case fatality rates. So we took the standard WHO guidelines, which are here. This is the way, a very simplified version of the way that COVID cases may be treated, with certain specifications about how much nursing care and what levels of oxygen. And we began to work and look at how that would be constrained. So some of you who are familiar with infectious disease modeling know that there are some forms of models which really sort of map out not just the different infectious disease states, but also within those states sort of have a sort of integrated pathway of care. And essentially that's what we started to look at, and started with a group of clinical experts and modelers and economists to try and look at the sort of optimal solution given the human resource and bed constraints that exist. And this is still work in progress. I would like to show results. We haven't got it, but it's really to explain the principle. I think in South Africa there will be work, there's equivalent work going on in South Africa, and that will be published shortly. But it's just to explain what we're beginning to work on. But to give you an example, so I didn't have a COVID example of that kind of work, I wanted to give you an example from TB. And this doesn't so much look at the human resource constraint on care pathways, but is an equivalent example for case finding. So this is an example from South Africa from a few years ago, and work done to support the national strategic planning there. And here we were asked for TB to look at various policy choices. So one, and some of you will now be familiar with this from COVID, one is to increase the use of a PCR test called Expert. Another one was to increase adherence to the algorithm that you use alongside the PCR test, particularly how you treat people who are told that they are negative, just to make, because it's not a perfect test. So another intervention is to have the test, but have a reinforced algorithm for when people are negative. And then other, which are sort of more screening interventions. So intervention 5 and 6 here, really screening everyone who has a cough who walks in, or sort of different patient groups as they walk into different facilities, and also screening people with a different type of symptom screen that is more specific. So ask people, have they got their cough, but also another set of symptoms alongside the cough to be screened. So we were looking at these different interventions, but the type of, and I think that's, you know, that kind of work has been done before in TB, but what we wanted to look at was what actually is the optimum if your human resources are constrained. So on the left-hand side, you have, so if you look at intervention 2, which is increasing the use of PCR, you have sort of the darker shades are when it's not constrained, and the lighter shade box plot is when it is constrained. And what you see on the y-axis is reduction in incidence. So for some of the PCR type interventions, there's very little impact of human resource constraints on that intervention in terms of overall reduction in incidence. However, if you go to intervention 10, which is a combination of some of the other interventions, and probably the most the most costly, here you see that actually the human resource constraint substantially restricts what you're able to do. And in fact, if you look at the white bar, that combination doesn't get much further above some of the more simple interventions of just expanding access to the PCR machine. And this again was taking quite liberal assumptions, I would say generous assumptions, in terms of the ability to sort of using up, in terms of the ability to add to the human resource workforce. So this was, I think, quite a conservative estimate of how much human resources would constrain these different interventions. So that gives you some example. So I've talked about sort of cost to the health sector, but of course, you know, costs are much broader to society than the cost of the health sector. And I'm just going to talk a little bit about the direct cost of illness. This is not overall macroeconomic impact, but lots of attention in recent years is also focused in terms of particularly lower middle income countries who don't benefit from universal health coverage. What is the impact for individuals who have health shocks? And there's been quite a lot of work looking at the different type of costs that people incur, from lost productivity from feeling ill to actually the cost of informal carers, other costs such as cost of special food or supplements that go alongside illness, costs of guardians, etc., etc. So you can see, once you start to think about it, that a health shock actually potentially may have quite a severe impact on families and households, even before the kind of public health or physical distancing interventions. So again, when we first did our work in COVID, we tried to look, and this is again not looking at the sort of broader impact of physical distancing, just of an unmitigated epidemic in terms of the cost to households of that happening with no intervention. You can see from this diagram that the income loss and the out-of-pocket expenditures we would expect actually equal, or near enough equal, the cost of actually treating people. So the kind of GDP estimates we have from the health sector side were substantially increased once we start to consider the overall cost of illness to society before you actually intervene. So I talked about supply side constraints and the impact they may have on different interventions and how that may change the way you choose your policies. The other side is the demand side constraints, is their uptake and how people decide to adhere or not to interventions, which is something that Deirdre also touched upon. So just to first sort of mention this basic, which I think probably is well known, but just to sort of start from the beginnings again, when people make decisions in respect of whether they utilize healthcare, they'll be balancing, in very simple terms, very parsimoniously, they will be balancing maybe the economic risk more generally against their health impact of making decisions. This is just two dimensions, and within that economic side is all other sort of forms of consumption and production going on, and it's sort of trading off those two things. So what you'll have is, if people are considering their own trade-offs, you'll have the group in the top left-hand corner. These are people who potentially, if they don't do anything, will have a high health impact, but they have a very low economic risk of acting. And those people may choose to adhere to an intervention, whether that be physical distancing or actually seeking care. In epidemics, you may see, particularly pandemics, which are pervasive, you may also see altruistic behaviors. So people, even without any government interaction at all, you may find that people do consider that, and actually more people will still seek care or act appropriately, balancing health or economic risk. The issue for governments is that optimal? And if it isn't, do they need to act to ensure that overall in society, that the overall social welfare and the balance between economic and health trade-offs is optimal, considering the fact that individuals infect one another and may not be fully considering that when they're taking their individual actions. So that's the sort of basic principles of the way economists look at how people behave and how they're making these choices, and the role of governments in terms of intervening in those choices as part of this decision frame. However, in addition to that general, if you like, constraint that people may not act as altruistically to benefit society, but on their own, there's also their ability to act. And this is very much where the two talks align. So here's one example of some work that, again, we're beginning in COVID. This has only been a few months in, but we talked about, you know, economic and health risks and how these two affect decisions. So there are various things which can impact the risk of economic loss. It can be job stability, it can be your savings, your other capital you have to protect you, but also access to social protection. And in the case of COVID, ability to still maintain your incomes from working from home. And I think it's probably familiar with all the kind of infection risks. And these will determine whether you seek care or also whether you adhere to physical distancing. And your overall health outcomes will depend on that, but also various comorbidities, which in turn may also be determined by your economic status. Importantly, and it would be great to have simple things to model, but this isn't. Importantly, those health outcomes in turn may impact, as we've seen, your economic outcomes. So if there's a death in the family, particularly in poor families, that might have quite a catastrophic economic risk, and in turn that will come back and affect the rest of the decisions that that family makes. So our work on COVID risk, we tried to explore which groups in the population or which social economic status groups are forced in this trade-off between economic and health risk to take risks. So we looked at country level data on employment by occupation. So we understood we took about 10 low middle income countries and broke down the sort of population of the economic sectors in detail. And then went through each and looked at the record in terms of lockdown policies and tried to identify which jobs were considered essential and which jobs were from closed industries during the lockdown. We also used some work from the US to look at which of those jobs were teleworkable, so could still be continued, and also looked at a sort of broader database to understand the patterns of social protection during the pandemic, and then took all these things and looked at them by social economic status quintile. And the kind of work we're doing sort of results in these kind of graphs. And again, this is preliminary, and I think we will put it in open access the week after next with further work on this. But this gives you some idea across different types of countries for each quintile, which groups are probably able, what proportion of the different social economic status quintiles are able to protect themselves, depending on whether they are, and when we say no income, these are family members of people who have income, or they can be people who are in the informal sector. And then we divide the earning groups into those who are able to protect themselves and those who are not, and also social protection. If you look at the green, that's the sort of proportion of the population by different quintiles who will find it difficult to protect themselves against health risk. And it's quite interesting because it's not always the lowest income group that's actually most at risk. Because of the need for essential work, you often find, well, in some of the countries you're finding quintile 2 and quintile 3 also face quite high risk, and it's really only quintile 5 which can protect themselves. So I've talked a little bit about a very sort of blunt way of, or not blunt, but hopefully still useful way of understanding sort of economic risk and ability to adhere, looking at employment. Obviously, within different diseases, there are also specific mechanisms. And just to sort of give one example also from TB, this is another approach you can take, where you actually look at the different stages of the disease and look at the specific mechanism between social economic status and the disease at that particular sort of part of the disease trajectory. So in TB, for example, it's not just sort of, we know social economic status related to TB incidence of disease, but then that's that's implemented at different parts of the disease. So different factors influence the risk of infection compared to developing the disease. One piece of work we're currently doing, instead of sort of looking at the broad relationship between social economic status and disease, is really to try and specify those different links and how they relate to different sectors. So again, this is in the case of TB, you'll find that TB outcomes may well put poor households further into poverty or sustain poverty. That will actually affect different types of consumption on food or consumption using stoves or fuel. And actually through that mechanism, you'll affect nutrition and also indoor air pollution, which will in turn affect TB. So you can see that's a slightly more direct understanding for a specific disease of the relationship between the economy and those health outcomes. Okay, I'm going to begin to wrap up. I'm sure I'm getting probably near to my time, but hopefully I've provided some examples both from our existing work in TB and the work that we've tried to do for COVID of kind of joint epidemiological and economic modeling. I think one of the frustrations of the last 6 months is it's been very much doing separate analyses which have been hard to bring together in combined models. So bits of information, which I think must be difficult for decision makers to have one sort of bit of information on behavior, one bit of information on economics, one bit of information on health impact, not sure whether they all matched up. And that's been very typical of the kind of analyses that we've been producing as well. I think one of the challenges, at least in this epidemic, is this work has really been running behind the decisions. I think what people are seeing in their everyday life is this very close interaction between the economy and health. But unlike the epidemiologists, we didn't have joint economic and epidemiological models set up. So the speed at which we've been able to generate results has been much slower. And that's, as I say, not just because of us, but also because different decision makers have wanted different bits of information depending on their interests. So, for example, the WHO has a strong demand for our health impact work, but the World Bank has been very interested in our macroeconomic modeling of COVID. And they've all had different questions, but not combined questions. So in terms of future pandemics, what I'd really like to see in terms of our preparedness going forward is work done beforehand to really evolve this kind of very patchwork work linking economic and epidemiological models together. You know, one way of doing it, which has been the way of, I won't speak for the NTD consortium, but I'm part of the TB modeling consortium and have been involved with the HIV one, has been linking economists and epidemiologists together. And again, sort of pulling together these different sort of analyses, often focused primarily on cost effectiveness. But some of these analyses don't actually internally have feedbacks between those two elements. It's more, you take an economic model and you add in the impact from the epi modelers, or you have an epidemiological model and add in cost to that, but they actually don't look at the interaction between those two elements. So going forward, I think, and I hope I've demonstrated that this sort of understanding the link between economic welfare and health impact actually requires perhaps joint modeling. And that will be difficult for both types of modelers. I think if you work with the macroeconomic modelers, or even the people who are modeling health sector impact, they're very reluctant to let go of any complexity in their models. In the same way, when you work with epidemiological models, they may be focusing on things like age structure or other things. And when you start to bring in social economic status, it all becomes very complicated, and working out the data for each age group by social economic status is too complex. But instead of dropping the age structure, it'll move, that choice won't be made. So I think sort of we do require people who come from both perspectives, but also being willing to sort of simplify both sides of the models to have combined models. And that's something which I hope there's some discussion on going forward. In terms of data, one of the, I think Deirdre mentioned this, I think in lower middle income countries, we've had to rely on sort of quite poor social contact data, often not readily available from that setting. And often only available in terms of mixing between population age groups, but not understanding how different social economic status or economic statuses, economic groups are interacting with one another. So for example, in talking of Deirdre's heterogeneity, it may be reasonable to think that when COVID entered many lower middle income countries, it was primarily entering through high economic groups, and the rate at which they interact with lower or not lower, poorer groups, I think is probably been quite pivotal to the progression of the epidemic. And finally, one last comment before I thank people. I know the talk and the focus of this is all about future pandemics, but I just want to note a word of caution. I think Deirdre did this very well as well, that actually our questions in this joint modelling shouldn't just be for future pandemics, but actually is probably key to understanding whether COVID will become endemic or not. And a paper that I wrote with Graham Medley, and thank you to him, sort of looks at the way as diseases become fixed in certain economic groups, they then become tolerated. And in fact, that means that they become endemic and stay circulating in those groups, even though they still have as higher impact as, say, COVID. And I think TB is an example of that, that it is still conceivable that TB will kill more people than COVID this year. but nevertheless it affects very different populations. So I want to thank many people. We've been working the last 6 months with a large group of about 20 people at the London School, economists, modelers, and our collaborators in Kenya, in India, in Pakistan, and in the Netherlands to produce this early work. And I want to thank particularly the Wellcome Trust and UK Aid. As you can see, it's quite patchwork, but nevertheless has required a huge amount of work even to get this far. So I thank all of those people listed here. And I'll stop now. Thank you very much.
Thank you very much. That was really super, very, very interesting indeed. Well, we wait for questions to appear. I have to keep looking at two different screens for this. I totally sympathize with this idea that we need to develop a forum so there's more interaction between economists and epidemiologists. And we've been trying to do this at various locations, but this is sort of difficulty of it'd be great to have a Newton 6-month type meeting on this, but how do you buy people's time out for 6 months and get the right group of people to do that? Or could you do it as we've done in the past in the US at places like NCEAS and CISINC, where we have people come in for a week at a time, 4 or 5 times over a course of 1 or 2 years, and begin to develop collaborations between each other. But what sort of model would you envisage for that as a way to get this done?
Yeah, I mean, I think the important thing, well, I've been involved in the TB modeling consortium, where we've really tried to get this interaction between economists and epidemiologists. And I think we have made progress, but one of the ways that there are 2 ways in which it hasn't worked, which maybe we can learn from. The first thing is not, for economists, is not to be disease specific. I think I've worked maybe 10, 15, no longer in TB only, but that's very rare. Most economists will work in TB one moment and HIV the next moment, and that can make them very bad epidemiologists. Right. On the other hand, it's important that they are sort of, they need to be brought together with a mixture of people looking at different diseases. So I think that's one of the ways that's important. And I think the other way is economists, and I'm sure it's the same with infectious disease modelers, is health economists specifically, we're quite an instrumental profession because we're so aligned to policymakers. And I think one of the struggle, and that's good, we want to influence policy, these are big issues, we definitely want to influence policy now with COVID, but the underlying scientific work is sometimes difficult to achieve and have discussion around, because we're so busy sort of generating the latest cost effectiveness ratio, or the latest model, so latest. So I think there isn't much space sort of at the more fundamental level to look at different model structures when the question isn't a sort of an immediate question from a policy maker. So I think that's been my struggle in the last sort of number of years, is to try and get interest and in people who are interested in working more fundamentally rather than just producing for a specific policy output. So I think those are 2 things I think it is a useful space, but that needs to be created.
Excellent, I totally agree. So we should talk more about this. A question has come in from Anonymous, asking, is COVID-19 changing the paradigm for health economics because non-health economic costs are now forefront in decision making?
Yes, it has changed. I think if you look at bodies like NICE, they haven't really dealt with a societal perspective. In fact, they push back. They've said the health budget is constrained and we shouldn't ever assume that it's going to change rapidly within the UK. I think the difference about pandemics is the health budget itself changes, the whole economic structure changes. So I'm not sure that we will go back and apply that to within health sector decisions when the budget is more constrained, but I think there will be, I think we will understand that some public health measures require that change in thinking. Sorry, and that's a very broad thing. I'm really sorry. I do have to go.
No, fantastic talking and good luck.
I'm happy to take email. The other thing is my email address was on my presentation, and if anyone's interested in following up, that I welcome people emailing me.
Excellent. Great. Super talk. Thank you so much.
Thank you. Okay. Bye.